Good morning and welcome to today's webcast, Getting Started with Pathways to Success. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
I'm pleased to introduce today's presenter from Los Adams, Georgia Green, Manager, Strategy and Integration. And with that, I will turn it over to Georgia to get us started.
Thank you so much, Emily. I appreciate that, and I appreciate everyone being on the line today. I'll just say really briefly about myself. I've been working in the ACO world, working with the Medicare Shared Savings Program since 2013. So it's really been my world for the last, 6 years or so, and worked with all different types of health systems. And today I just wanted to put together a presentation that gives you a really comprehensive background of, why this program exists, how it works. There's a lot of detail in the slides, so you'll have a copy of that you can reference when you need to in the future. And I just want to encourage you as I go along, feel free to put questions in the Q&A box. I'll do my best to monitor that. And I will get to them at the end if need be. But please feel free to reach out to me during the presentation or afterward. I'd be happy to chat with any of you about your questions about this program or other Medicare programs. So with that, we will talk about kind of the big picture background, understanding MACRA, MIPS, the Quality Payment Program, kind of setting the context for what's going on in healthcare right now. And we'll look at alternative payment models and the transition to value-based care, and then hone in really specifically on the Medicare Shared Savings Program and what is now called Pathways to Success. That was a big overhaul that just started this year. So we'll get into the detail on that and also look at ACO strategy and how to get started with the application. So here I have a quote from Seema Verma, CMS Administrator, and this is fairly recent, end of September, and I'll put on my Seema Verma hat and say, continuing to pay based only on the volume of services is neither sustainable nor affordable for the American people. Value-based care is the future of healthcare. outside of healthcare, customers make virtually every economic decision on the basis of value and performance. Why should our industry be so different? We know value works. We've seen costs go down and quality go up when we exchange fee for service for a payment system that aligns incentives to foster and drive efficiency. So I really love this quote. I think it really captures what's going on. As you see this arrow, there's basically a big transition right now from fee for service, which is essentially saying the more services you do, the more volume you do, the more you get paid. And that has driven how healthcare has worked for the last lifetime for most of us. Toward a fee for value system. And the value equation is here. You don't have to be a certified public accountant to understand that value happens when you have high quality at a low cost. So very simple math. That is essentially what the new programs coming out of Medicare are trying to incentivize. High quality and lowering or at least stabilizing the growth in cost, reducing the magnitude that it grows each year. So what is MACRA? The Medicare Access and CHIP Reauthorization Act. MACRA is a law. When you hear MACRA, they're talking about the law. It's legislation that passed in 2015, really updating the Affordable Care Act, has total bipartisan support. It created the Quality Payment Program, QPP. And for those of you who have been working in the quality space since the Affordable Care Act, you know that there's been kind of a myriad of different programs. EHR incentive program, reporting meaningful use, PQRS, the physician quality reporting system, the value-based modifier in the hospitals, all these different things to evaluate the quality of services that we're providing to our Medicare patients. And it was a bit overwhelming to report all these different things, and they affect payments in different ways. So the QPP essentially combines all of these disparate systems into one portal and one process. And so essentially every provider by default is a MIPS provider, and that is the merit-based incentive payment system. And there are 4 categories that we report on. So you can see them at the bottom. I think of these as kind of 4 buckets, and they have different weights, and those weights change from year to year. So we've got quality. These are clinical measures, improvement activities, cost, and advancing care information, which ACI, advancing care information, is just the latest term that CMS is using for EHR meaningful use. And so basically everyone falls into this MIPS bucket unless you're a very low volume provider and might be exempt from it. And certain rural providers are exempt as well. But for your typical PPS providers, you can sort of level out of the MIPS system by participating in an alternative payment model, such as the Medicare Shared Savings Program. And for those who are in the lowest track, the not risk-bearing track of the Medicare Shared Savings Program, these are considered MIPS APMs. And then if you take on higher levels of risk and higher levels of reward, you can see a list of kind of example programs there. You can become an advanced alternative payment model participant. And if you sort of do enough billing under this model, qualifying participants would be in this AAPM category. So they would not have to report on MIPS at all. So what does it matter that you're in MIPS or MIPS APM or an advanced alternative payment model? Basically, you get a score out of 100 points at the end of each year based on how you do in these 4 categories. And that score then sets your Part B payment adjustment 2 years later. And my next slide has a nice timeline that Medicare put out that when they first announced this program. But essentially, all providers are placed on a bell curve. This whole program is budget neutral, and it reallocates money from the lowest performers to the highest performers. So you really want to be on the high end of that bell curve And you can have a positive or negative payment adjustment just based on how well you do and if you meet certain performance thresholds in these 4 categories. So the reason why some providers would be incentivized or would want to be in this advanced alternative payment model bucket, and they're willing to take on risk because they get that automatic plus 5% payment adjustment. So that's a pretty good incentive. In the first 5 years of the program, there's also an exceptional performance bonus, $100 million a year, that is, divided up amongst providers that are really in that top 1% or get the highest scores. So this is just a timeline. I haven't seen Medicare put this out since the very beginning when they first announced it, but you can see what they did is essentially freeze the physician fee schedule updates. And this year, we're at 0%. So essentially the fee schedule is not going to keep up with inflation. And then any individual provider's bonuses are based on their scores in MIPS or whether they're in this advanced APM category. In reality, the ACOs I've been working with, even an ACO I just reported with for 2018 got a perfect score, 100 out of 100 on MIPS, and so they got the exceptional performance bonus, and that did not equate to a plus 5%, as you see for 2020 in orange in the middle there. It was really only plus 1.68%. And the reason that is like I mentioned, because it's budget neutral and it's allocating a certain amount of funds from the low performers to the high performers. And the reality is that there are a lot of high performers in this program that are getting very high scores. So we'll see this start to change as they make the thresholds higher and harder to achieve. But for now, you can see by being in this MIPS category, the reward's simply just not as great as getting that automatic plus 5% bonus. So what are these alternative payment models? They're mostly being tested by CMMI, the Center for Medicare and Medicaid Innovation Center, and there's all different types. I mean, they've tested many different types of models in different places, but some of the main ones are accountable care organizations, where a group of providers becomes accountable for the total cost and quality of care for an assigned population. There's bundled payments, and so in this type of program, there can be an episode that initiates a bundle. And so, that might be a surgery and the 90 days following a surgery. And essentially, it's like you're being given a budget for what's the maximum that you'll get paid for that episode of care. And there's also geographic models, state-based models or regional models where providers become accountable for all the patients in that defined geography. And of course, with all these programs, there are carrots, there are sticks, and we're seeing, as sort of early adopters probably received the most carrots. And as we, go along over time, there's a transition toward reducing those carrots, increasing the sticks, making models that were voluntary into mandatory models, for example. And all of this is due to the fact that basically Medicare has stated and continues to say that they want 100% of Medicare payments to be in alternative payment models by 2025. So they're really trying to kind of usher providers into these models. And, like I said, with both carrots and sticks. Here's our first polling question. I'm going to hand it over back to Emily.
All right, thank you. And our first poll, has your organization begun the transition to value-based care? And your options are A, no, we operate in only a fee-for-service model. B, yes, we currently participate or previously participated in an alternative payment model with Medicare and or other payers. C, we are in the analysis and strategic planning phase, or D, not applicable. And I'll give everyone a few moments to respond. To participate in our polls today, please click the button next to the answer you choose and hit submit. Give everyone a couple more seconds here. And let's go ahead and take a look at the results. Georgia, back to you.
Okay, excellent. Thank you. Yeah, so it looks like the majority are currently participating or previously participating in some alternative payment model, and that doesn't surprise me at all. These are really widespread models. So let's get into the details about the Medicare Shared Savings Program. So I have a little graphic here showing you that an ACO is essentially an umbrella. That's what the little umbrella is for. And under the ACO, you have participants that are defined at the TIN level. So whenever I say participant, I mean tax ID number that's enrolled in Medicare. And then all of the providers who bill through that TIN are ACO providers. So really, the Medicare Shared Savings Program is a transitional payment program. Like we said, it's all about taking that jump, making that transition toward fee-for-value payments. And it's a program that focuses on preventive care, primary care, population health, and care coordination. The idea is that the ACO and its participants, everybody who is under this umbrella together, becomes accountable for the total cost and quality of their attributed patient's care, and that is whether the care is occurring inside the ACO or outside of the ACO. So in a sense, you start to take ownership of your patients, the patients that come to you for primary care, and think about, wow, what is the total cost of this patient's care and how can we help manage that? So who will those patients be? Medicare attributes patients to you if they receive the plurality of primary care services within the ACO versus outside of the ACO in the prior year. So plurality is just a fancy word for the most dollars spent, most money spent by, most claims paid by Medicare for that patient. So what they do is they look at the patients in their cost in 3 benchmark years. So if you were starting in 2021, your benchmark would be 2018, 2019, and 2020. And they compare their cost, their total cost of care in the performance years. And what we are working with now in the Pathways to Success program is a 5-year contract. So you'd be signing up for 2021 through 2025 to be in the program. And it is a bit complicated how they calculate cost and compare that in the benchmark versus the program year. But essentially it includes weighting of different patient categories, and the benchmark years have, they're more heavily weighted more recently. There's truncation at the 99th percentile, so extremely expensive patients basically get ratcheted back down to the 99th percentile cost. There are national and regional adjustments, and it utilizes the HCC, the hierarchical category condition codes that really determine the severity of illness of the patients. So if you start the program in level A or B, or you may have heard this called Track 1, it used to be called Track 1, it's really a bonus-only program where you can receive a shared savings bonus payment if you reduce the overall patient cost, and there's no penalty to you if the costs go up. So this is, really kind of the safe place where most ACOs start, and the vast majority of ACOs are in this kind of Track 1 program or risk-free program. To comply with the program, you need to report on their set of quality measures annually, and this quality performance score that you get will adjust your shared savings payment. So in the first year, it's what they call pay for reporting. In year 2 and beyond, it's pay for performance. So your quality score can impact how much shared savings you earn. And what's really nice is that your billing and reimbursement processes do not change. So whether you're a PPS hospital or a clinic or a critical access or rural health clinic or FQHC, however you're billing Medicare now does not change in the program. The program essentially is a calculation that's done at the end of the year. If you're a more visual person, you might like to see this. So this is just a really high-level example, hypothetical example. If your ACO's benchmark spending per patient is $10,000, and then you see this teal-colored arrow, you implement all these wonderful ACO programs. So you're doing care coordination, and you're ramping up your annual wellness visits, and you do this initiative to get everybody's flu shots done this year, and you're managing the chronically ill, and you bring the average patient spend down to $9,500, you've created $500 per patient of savings for Medicare. And if you weren't in this program, Medicare would say thank you very much and put that $500 right in their pocket. But because you are in this program, they will share the savings with you. And so when you start out in track A, level A of this program, you get 40%, so you would get $200. And then you see it's multiplied by quality. So as I mentioned, in the first year, you get a 100% quality score just for reporting. In year 2 and beyond, your quality score is going to impact your ultimate payment. So let's say you get 85 percentile quality score, you're going to end up with $170 bonus payment from Medicare. And then you can take that, and your ACO has its own policy about how you share a portion with your providers as a bonus to providers, and how you reinvest those funds back into the ACO. So I'm not going to read this whole slide. It's just a reference slide, but these are the primary care services that Medicare uses to determine if your patients had the plurality of care. And it's just worth mentioning that the patient has to have at least one visit with a internal medicine, general practice, family practice, pediatric, or geriatric provider. And if that's within the ACO. And if they don't have any visits with someone of those specialties, there's another list of specialists that are kind of secondary, but the vast majority of patients have at least one, of Medicare patients have at least one visit with one of these types of practitioners. So let's think about the requirements a little bit. So you probably have heard, maybe not, that an ACO needs to have a total of 5,000 lives attributed to get approved in the program. And it is very sad. I've done a couple of these applications with ACOs that just come super duper close and have 4,600 lives. And Medicare will not approve you if you are, one life short. You need to have 5,000 lives in all 3 benchmark years based on your list of providers that you give them. And all the participants need to be Medicare enrolled, of course. Now, so that is kind of a hard and fast requirement. What is really nice is that the programs are flexible. So Medicare is saying you need to have quality and performance reporting and improvement programs, evidence-based medicine, care coordination for your chronically ill, patient engagement, and a data warehouse, and reporting out to your providers. But they don't dictate exactly how you have to do that. So there's a lot of flexibility from one ACO to the next. How they arrange their care coordination program might be completely different, and it's got to work for your clinics and your facilities. And of course, strategically it makes sense to really align it with all the other, maybe commercial ACOs that you have. And then there are other, MSSP rules and requirements. So 50% of the clinicians need to be on certified electronic health records. You have to complete the annual quality reporting process, need to have a compliance plan, an officer, compliance infrastructure. There are beneficiary and provider notification processes to complete. You do need to keep the PCOS system and the ACO up to date about any provider changes, and that should be familiar. That's kind of a standard function of like a credentialing office to keep providers up to date in the PCOS system. But always worth mentioning because I can't tell you how many clients I've come across that are a little behind on their PCOS updates. Marketing rules you have to comply with and public reporting. Every ACO has a public reporting website. So if you're familiar with any Medicare ACOs, you should be able to go on their website and see who are their participants, the names of the people on their board and committees, and if they've been in the ACO in the MSSP for a while, you can see their performance on prior years. You have to have a board, and the board has to have 75% representation of participants. So essentially what Medicare is saying is that they don't want companies to own ACOs and control them. They want the Medicare providers to own and control their own ACOs. And that could be, hospital leadership that are the ACO participants. And of course, executive leadership as well. I saw a question come in the chat box that says, for assignment, thinking about those primary care codes, what about an urgent care provider? Would that count? That's a good question. So it really just would depend, if you are billing these codes, it's typically not urgent care. But I could see maybe someone who identifies as an urgent care provider billing for some of these CPT codes. But yeah, that's something I could follow up with you in a separate email if you want to kind of describe your specific situation. But typically these are, based on office visits in a primary care setting. So this slide's about quality reporting. It's an annual process. We do it in Q1 following each program year, which is, each calendar year. Data comes from an ACO CAP survey that's done by a vendor, and then some of the measures are claims-based, so CMS just calculates those and tells us how we're doing, and we also get quarterly reports on those too. And then there is a data abstraction process of demographic and clinical data coming from your medical records. And that is, something I have a lot of experience with and can help either execute or advise on. Also, each ACO participant needs to report on the promoting interoperability piece of the quality payment program. And those scores are all merged together and weighted to give the ACO one total score for promoting interoperability. And again, that's the same as meaningful use. So for quality reporting, CMS selects the patient samples and provides information about who those patients are, where they received care from, and then we report on at least 248 consecutively ranked patients. Usually I see about 3,000 patients get sampled for an entire ACO. And there are 23, now this year, there are 23 measures in 4 categories, and only 10 of those measures require clinical data abstraction. So if any of you were involved in data abstraction and reporting last year, there were 15 measures, and CMS very kindly reduced the number to 10 for this year. So I'm happy about that. It is possible after the quality reporting period in April or May to get selected for a validation audit. That's not random. They'll pick you if you have shared savings. And the audit process is fairly straightforward, but has to do with submitting screenshots or evidence based on what you submitted in the quality reporting period. So there were some changes that took place in 2019 called Pathways to Success. It changed the program from a 3-year to a 5-year participation agreement and created what they call the glide path. So instead of kind of staying in the same risk arrangement for 5 years straight, you automatically advance up a level every year. And you can opt into a higher level, but you can't move back down again. So just my personal recommendation is to start at level A and just work your way up over time with increasing risk. One nice change is that they allow you to annually select the beneficiary assignment methodology. So there's prospective assignment, where you're given a list of patients at the beginning of the year, and that stays your list through the end of the year. You know that these are the patients that you will be evaluated on for cost and quality to earn shared savings. Retrospective assignment looks at the list of patients at the end of the year and looks back and says, okay, these are all the patients that saw you this year. They came to you. And so you may end up with more patients, or you may end up with a bit more accurate, depending on your geography. If there's a lot of turnover and migration of patients, that might be a better way to do it. And there's some other strategic benefits. I also recommend a retrospective assignment method. They had some other rules that really apply to level C and up, where they expanded the SNF 3-day rule waiver, expanded their beneficiary incentive program, made some changes to their beneficiary notification requirements, unfortunately kind of expanded those requirements. This program is very solid in the sense that it has bipartisan support, but there are requirements that fluctuate from year to year in terms of these notifications or quality reporting. So this is just a graphic about the levels. There's A through E, and then once you complete that 5-year cycle, you would move into the enhanced program. And under some circumstances, some ACOs could repeat, just staying at level E. And so I just highlighted in green that when you're in level A and B, it is a one-sided risk model. So you only move into two-sided risk, where you potentially could owe Medicare a shared losses payment if your costs go up when you get to level C. And then when you get to level E, you achieve that advanced alternative payment model status. So then you're getting the automatic plus 5% payment adjustment on your Part B payments. And if that table didn't make total sense, it really starts to make sense when you plug in the numbers for your organization, how many patients you have, what the average cost of patients are, and then you can really start to see what your potential shared savings or losses are and how much is at risk. And that's something I can help you with if you want a better sense of what does this really look like for our organization. So there are a lot of benefits to this program. That is why it is such a popular program. I think we're up to 559 ACOs in the country. So, it's patient-centered. It's got a primary care focus. As I mentioned before, there are very general requirements, but there's flexibility in how you implement them, which is really nice. If you are a data nerd, which I am, it's super cool because you get complete claims data on any patient who receives a primary care service within your ACO. So you get a 12-month historical look back, and then you get a monthly updated report that they call the CCLF files, claims line feed files. And so it's not just for your organization. You're seeing everywhere that this patient had paid claims with Medicare. And that can be really helpful, especially if you live in a population with snowbirds or people that are not there all year and not receiving all their services from your health system, which is rarely the case. You can really start to see what leakage and keepage looks like for your health system. There's no changes to your billing process. There's no geographic limits. So I have set up ACOs with participants in Mississippi and Washington, or California and Indiana. You know, it really doesn't matter where you're located as long as you decide to come together under the ACO umbrella. And that's something I can help you with. If you don't think your organization is big enough or has the resources to become an ACO, still reach out to me, because I can find a way to pair you with other organizations that you know, might be in the same boat as you, but together you would have the resources and the lives that you need to do this. You've probably heard that you get waivers in this program. So there are Stark and Anti-Kickback waivers, and also the ACO board can approve its own waivers. And so that's a nice benefit if the ACO board deems that your patients would benefit from a transportation waiver, and we should provide transportation for our patients to advance, you know, population health and clinical initiatives. That's something that you can do. You can achieve clinically integrated status for negotiating with commercial payers. The OIG has determined that just by the nature of being in the MSSP, that qualifies for that status. And it's, you know, a way to form that narrow, high-quality, highly efficient network. Of course, you have the opportunity to earn a shared savings payment. I don't think that anyone should hinge their decision to be in this program on earning shared savings. Just as an example, for ACOs that started in 2018, you know, first-year ACOs, 21% of them earned a shared savings payment in their first year. And I think that's pretty good, actually, given if you're new to the program. It just takes some time. It can take some time to ramp up new programs, new systems, and start to be effective. And ACOs, what the trend shows is that the longer they're in the program, the more likely to earn shared savings. By being in the MSSP, though, you become a MIPS APM provider for the quality payment program, and so you have a reduced and simplified quality reporting burden and tend to get higher scores just because of the way that those categories get weighted. ACOs just sort of on average would get about 15 points higher scores. And these scores are important because they're reflected on public reporting places like Physician Compare that consumers use, and of course because they impact your Part B payment adjustment. I like to mention that there's population health revenue opportunity. This is a really good framework. Being an ACO is a great framework for taking on that initiative and saying, okay, we're going to focus on annual wellness visits, and other ancillary behavioral health kind of services and preventive services. Not that you have to be an ACO to do that, but just that it's a great way to get alignment within your entire network and incentivize them to do that. So, you know, I've mentioned some of these other things, that your reimbursement's not at risk, that there's waivers when you get to level C and above, that, you know, can be enticing. And essentially, it's a way to prepare yourself for this future of reimbursement that Seema Verma, you know, is continuing to underscore is the future. Value-based care is the future of reimbursement. So this can be a good kind of low-risk way to get into that. Okay, so we're back at, that was a lot of content, and I'm going really fast, but I'll hand it over to Emily for a polling question.
All right, our second polling question: considering the MSSP requirements and benefits, check all that apply to your organization. And your options are A, with planning, the program requirements could be met by our organization. B, we could partner with other provider organizations in order to meet the requirements. C, we are part of an existing network that would qualify to participate as a whole. D, we have existing infrastructure, programs, and services that could be leveraged for the MSSP. Or E, not applicable. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. And let's go ahead and take a look at the results. Back to you.
Okay, thank you, Emily. Okay, well, it looks like our audience is pretty split here. Okay, let's keep going. So our next slide is about the performance results from 2018 for ACOs across the country. 66% of ACOs saved Medicare money, but 37% saved enough money to earn shared savings bonuses. So something I haven't mentioned yet but is worth understanding is that you need to earn a statistically significant amount of money, or if you're at kind of these higher risk levels of the program, you set the threshold of risk that you're willing to take. So if you kind of set a wide berth, it makes it harder to earn shared savings, but it also makes it harder to have to repay shared losses, or less likely that that would happen. And Medicare really underscores that, physician-led ACOs outperform hospital-led ACOs. This is a point that they tend to make. But I just encourage you, when you hear CMS give their, evaluation, to just think about their perspective. So of course, Medicare's perspective is they just want providers to save them as much money as possible. And that is one definition of success. That is the success of the program from their perspective. You, as the providers, need to be considering what is our definition of success. And, maybe you earn shared savings, but maybe just being in this ACO creates a framework that makes your organization more resilient, more sustainable, improves care for your patients, and integrates your network within your community in a really strategic way, thinking about your competitors, thinking about other market forces. Regardless of whether or not you earn shared savings, it still might be the right thing to do. So thinking of some strategic considerations, these aren't the only things, but these are some common themes I've seen working with different ACOs. This is what the network strategies team tends to lean toward. So short-term, very important priorities are to get your data warehouse integrated and your BI tools working so you can receive that claims data, and so that all the ACO participants have integrated data and have meaningful reports coming out of it. Chronic disease management, so that's setting up a care coordination program that's really focused on that top 10% of patients that make up 60% of cost in the system. Undertaking population health initiatives like annual wellness visits, using this claims data to look at your network and create a really high value network of post-acute care providers. And then the HCC coding initiative is also important, not only for this, but just about every alternative payment program that Medicare is using those HCC scores as part of their cost calculations. So I think that's an important strategy for everybody, regardless of this program. Long term, the idea is that you want to utilize all this infrastructure you've created to align multiple payers in value-based contracts. And so some of you on this call today probably already have commercial ACO or commercial contracts with some sort of value-based component, whether or not it's taking on risk yet. And some people might be totally new to this space and are just thinking that the Medicare Shared Savings Program is a good starting point. And I've seen it go either way. I mean, no two health systems are the same, of course. So the thing I do think makes sense for everyone is to create an infrastructure that you can then use across your entire patient population and be efficient with that infrastructure. So this is just a starting point. The idea on a long-term scale would be to transition to higher risk, higher reward contracts, and really position yourself, prepare yourself to succeed under capitated payments or whatever mandatory payment models might be coming next from these payers. And in some cases, payers want to do, use this as a starting point to move toward MA or commercial plans essentially becoming the payer. That's, a long-term trend we see in healthcare. So, things to consider for your strategy is competition, geography, the availability of services in your region, existing integration and network alignments that you have. Maybe you already have a clinically integrated network that you can use and to just kind of become an ACO. And any information you have about value already in your network is all really valuable for deciding kind of who you want in your ACO with you and what you want it to look like. A really common question I get from CFOs is just kind of, why in the world would we want to do this? This seems really counterintuitive that we would want to reduce inpatient utilization at our own hospital. And the idea is certainly not to do that. So, keep in mind this is a total cost of care program. And so the idea is to bring your patients close and to understand your patients, especially your high-risk patients or the rising risk patients, and keep them inside your health system with your care managers. Tighten up your referral patterns, reduce leakage. And also, what I've seen is a lot of health systems become very good at their population health billing. And really capitalizing on the opportunities there. Every year there's new primary care codes coming out of Medicare because that's the direction they want to go in. So it's aligning yourself with the direction that the payer is going in. It's about strengthening the relationships in your community with the independent providers. And it can also be, in some cases, a defensive measure. So in some regions, there's a lot of ACO uptake, and you might see the independent providers around your health system starting to align either in their own ACO or with a competitor health system, and that's really the last thing you want. You don't want your patients to be siphoned away from your system. So it's really creating an opportunity to align with your local providers. I'll just touch briefly on this population health revenue optimization idea. I mean, it really is, like I mentioned, kind of an alignment with the direction that Medicare is going and expanding primary care services. And most of these have no copay to the patient, although you have to be careful and you have to be knowledgeable about each of these codes and what's required. A lot of these things are things that you might be doing in your clinics, but not documenting correctly to be able to bill for it. So that's the kind of training I like to provide, is just, here's what you need to document, here's what the boxes you need to check and understand in order to systematically provide this and screen patients and give them the interventions that they need. So let's keep going. Oh, we've got another poll question. Emily, I'll hand it over to you.
All right, thank you. Our third polling question: what value-based strategies are you interested in pursuing? And again, you may check all that apply. A, Medicare Shared Savings Program. B, Population Health Revenue Optimization. C, other APMs and programs offered by Medicare. D, value-based contracts with commercial payers. Or E, not applicable. And for those of you that would like a copy of today's slide deck, you can download them from the folder that says Slide Deck and Handouts to the right of the slide view. We will also be sending the slides via email after the webcast. And just a couple more seconds. And let's go ahead and take a look at the results. Georgia, back to you.
Okay, thank you, Emily. Okay, yeah, so we've got a pretty even split here as well. Nothing's really jumping out. That's great. So, I just want to touch on kind of the philosophical piece about shifting from volume to value. There's a big culture and mindset change that takes place. It's not just about signing up for, one more program and one more contract. In some health systems that haven't gone down this road yet, I've talked to CFOs that say, well, it was a lot of work and, it was a big change in our mentality to really start to try to manage our patients, total cost of care and total experience, but we could just never go back to the old way of doing things. It's a one-way street. And it's about proactive management of that patient population, bringing them close, really having that customer service kind of perspective. And for some, again, it all depends on your health system. If these are existing services, then it's just an extension of existing care coordination and care teams that you might already have. But it also might mean expanding those services or creating new services. It's thinking outside of the box of just what happens inside your four walls, but the total cost of care and that patient's, access and start to finish experience in the health system. So I also want to mention there are many new models coming out, either proposed or recently announced. Actually, some of these ones, the rules, the requests for applications have come out recently, and we're going to be doing a webinar again in a few weeks on December 12th to dig into the details on some of these models. So if any of these things interest you, please do keep an eye on our website or in our emails and join us on December 12th. But there are other voluntary programs that you might consider, like the Diabetes Prevention Program and Opioid Treatment Program, that can help address certain subsets of the population if you're wanting to explore some of the Medicare opportunities but aren't quite ready for the Medicare Shared Savings Program. So yeah, please reach out to me if you have interest in any of these programs, and I'd be happy to share information. So for the Medicare Shared Savings Program, we're coming up to a new year and a new application cycle. And really the first, part of this, you're here today, it's already doing step one, it's identifying the opportunity. So it's reaching out to the stakeholders, that's, the leadership in your organization, maybe other leaders or health systems in your network, or, whoever you think might be in this ACO with you. It's evaluating the interest, it's starting to qualify your participants and think strategically about who you would want with you. Then planning. So creating a strategic, operational, and financial plan is very important. That's something I can help with, is just modeling this all out in a spreadsheet and what that might look like for your size organization based on your location and average patient costs. We do have some public data we can pull, and we can also use your data. There's also just some basic kind of decisions about legal entities. What will the ACO entity be? Is that something new or something existing? There's contracting, so you need to have a participant agreement. And this part of it seems straightforward because there are kind of template agreements out there, and there are certainly required elements that have to be in the agreement. But as I think most of you on the call would agree, contracting can certainly take some time when you have lots of people redlining and going back and forth and asking questions. So I always encourage people to just start as early as possible on the contracting piece and making sure that that gets in front of the right people. So there is a notice of intent to apply, and that's very straightforward. It's something I can help you submit online. That is due on May 8th. And these deadlines, when Medicare says May 8th, they mean May 8th at noon Eastern time, which is 9 a.m. Pacific time. I'm out here in California, so I always think of the day before. So it's really May 7th. And if you don't submit the NOIA, the Notice of Intent to Apply, then you won't be able to submit an application. This is a required first step to open the door. And then the application period will essentially be May to June. So the first due date is June 11th. And again, that's really June 10th. And we submit contract signature pages. We put together narratives and attestations saying that your ACO will meet all of the requirements. We submit an organizational chart. We list all the names of the board members. And this is a process. I think I've probably done about 60 ACO applications in my time working on the MSSP. So I have a lot of experience here, can help you get all your ducks in a row to make sure your application goes through without too much struggle. But I will say, after we submit, there will be an RFI, or request for information process, and typically we have about 3 rounds where we go back and forth with CMS, and the reviewers tell us, oh, we want to see this different, or we need these changes, and you have additional opportunities to add or delete participants. So don't worry, June 10th is not really the final date to get everybody signed, but you want to get as much as possible over to CMS as early as possible so that you have the chance to make corrections. And then we do that really all through the summer and fall, and then we have an e-signature process, and we have a provider list attestation. So Medicare pulls all the names of the providers out of the PICOS system and says, is this correct? And we tell them, no, it's not exactly correct. We need to add these and drop those, and we attest to that. And then the key authorized people log in and sign online. It's all done online. And if you get through, this entire process, and of course you have more than 5,000 lives, then you are good to go, and you begin the program as a Medicare ACO on January 1st, 2021. So I really recommend that, if you are interested in this, that you do get started with these early steps as soon as possible. And I also just have at the bottom here, getting your participants to update their PICOS enrollment is really important. I have run into situations where people aren't properly enrolled in Medicare, and so then that prohibits them from getting into the program. So just making sure that you're enrolled in Medicare, it's up to date, you have all the right individuals linked up to your tax ID number is important. And also, just strategically, you can start your program implementation even in this runway year, this lead-up year. So, if you need to build up your care coordination program or pieces of your IT integration, it's great. You don't want to wait until January 1st to get started. The sooner you get started, the better. And that just increases your chances of being successful in the program. So with that, I'll hand it back to Emily.
All right, our final polling question. What is your next step in applying to the MSSP? And your options are A, we need more information about the MSSP. B, we are ready to provide education to our leadership and other stakeholders. C, we are ready to develop and execute participant agreements. D, we are definitely not applying to the MSSP in 2021. E, not sure about our next steps. Or F, not applicable. And once you have completed all CPE requirements, you will be able to download a PDF of your CPE certificate from the CPE progress window to the right of the slide view. And let's go ahead and take a look at the results. Back to you.
Okay, well, it looks like many people are not sure about their next steps, so that means that you're welcome to reach out to me anytime to ask questions, and if I can help you kind of understand what the next thing that your organization can do to move toward participation, I'm happy to do that. I also wanted to note that there are a lot of existing Medicare ACOs, and maybe a local ACO may have approached you about joining their ACO. And there's also a lot of ACO management companies that form your ACO and then charge fees, or they just take a large portion of the shared savings from the participants. So I have here some key questions to ask if you're thinking about joining one of those ACOs. And I know we only have 1 minute left. We're at the top of the hour, so I think I will just wrap up and let you know that we here at Moss Adams can really help you navigate this process. We have expertise on the program rules, timelines, budgets and financial planning, how to get your contracts completed, how to apply, how to distribute shared savings. I do trainings all year long for current ACOs and help them with their quality reporting process. So, if any of these services, whether it's all of them or any one of them, seem like something that you would like support with, then please do reach out to us. That's something I'm happy to help with. My contact info is up on the screen, but please reach out anytime. Again, my name is Georgia Green, and I'm georgia.green@mossadams.com.
All right.
Emily,
thank you,
anything
Georgia,
else?
for a great presentation today. We are at the top of the hour, so unfortunately we won't have time for questions. However, as Georgia just mentioned, you can feel free to reach out directly to her. Her contact info is here. Or you may still submit a question in our Q&A window, and we will do our best to follow up with you. As a reminder, if you attended today's presentation in a group and met all certification requirements, you must complete the group attendance sheet found in this slide deck and handouts window to the right of the slide view. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE progress window to the right of the slide view. I'll keep the webcast console open for a few minutes to give you time to download your CPE certificate. A copy will be emailed within 3 weeks should you have any difficulty downloading it now. Here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey as your feedback is very important to us. Thank you for joining us, and we hope you'll join us again next time.